We'll go ahead and start. First of all, thank you everyone for attending our monthly Dunlevie meeting. Before I introduce our wonderful speaker for today, I have a few of our center updates. I'm delighted to announce our fall 2022 seed grant awardees from the Dunlevie Center. Yair Blumenfeld for his assessment of a novel fetal ludo shunt, the Vortex shunt. Dr. Anna Pasca for identification of neuroprotective compounds for hypoxic brain injury using high throughput screening platforms in cortical organoids. And Dr. Alexandra Butwick, understanding hospital level variation in the quality of epidural labor analgesia among patients intending vaginal delivery. These were competitively reviewed and selected among the top scoring projects. And so congratulations to our awardees, and thank you for our multidisciplinary reviewers who spent time and effort thinking through these projects and reviewing them and ranking them. Next month, we will have the pleasure of Dr. Allison Cahill, who is professor of obstetrics and gynecology and director of health transformation at Dell Medical School in Austin, Texas, and she will be presenting on evidence-based management of the second stage. But to get to our wonderful speaker for today, it is my honor and pleasure to present Dr. Juno Obedin-Maliver, who is an assistant professor in the University Medical Line in our Department of Obstetrics and Gynecology, and also by courtesy, the Department of Epidemiology and Population Health. She is also the section head of the LGBTQ+ section in our Division of Gynecology. Dr. Obedin-Maliver completed a Bachelor of Arts in Women's Health and Natural Sciences at Hampshire College, went on to Stanford University School of Medicine for her Doctor of Medicine degree, went to University of California, San Francisco for her internship and residency, and then a fellowship in clinical research women's health following that, as well as a master's of advanced studies. She spent the first part of her academic career at UCSF before we were very fortunate to recruit her to joining us here in 2019 at Stanford. She practices the full spectrum of gynecology. She specializes in the gynecologic and reproductive healthcare needs of sexual and gender minority people, which includes, but are not limited to, lesbian, gay, bisexual, transgender, queer, and questioning people. This interest and experience drives her research interest towards promoting the health and well-being and equity of LGBTQ people. Dr. Obedin-Maliver has over 60 peer-reviewed publications, is the co-director of the PRIDE study, a multi-site online prospective longitudinal cohort of sexual and gender minority individuals based at Stanford. She also serves on the medical advisory board of the University of California, San Francisco Center of Excellence for Transgender Health, and is helping to author the next version of the World Professional Association for Transgender Health Standards of Care. Dr. Obedin-Maliver has been active in health policy, including involvement in helping to legally redefine consideration of sexually intimate partner status and to remove the Medicare non-coverage determination ruling on gender-affirming surgeries. We are delighted to have Dr. Juno Obedin-Maliver here today as our December speaker for the Dunlevie Center. Juno, it is all yours.
Thank you so much. It's such an honor and privilege and just fun to get to hang out with colleagues in this kind of setting. I am going to attempt to share the screen. Hold on, please. Let's see here. And let's see. Can I get a thumbs up? Excellent. Okay, so I know many of you on the call in different capacities. What I'm going to be hoping to convey and share with you today is some around pregnancy and birth outcomes among sexual and gender minority people. And I never thought I'd be, speaking using a Donald Rumsfeld kind of concept here, but exploring some unknown unknowns to drive how we think about accuracy and equity. The work that I'm presenting here is from I'm the honored, representative of it, but it's really the work of many, many, many people, some of whom I've named on this slide, some who are in the audience, but not everyone. There's big teams behind what I'm doing and going to be sharing with you here. Just in the interest of disclosures, really fortunate to have some different sources of funding, NIH, Corey, Society for Family Planning, and our own home, Stanford MCHRI, as well as institutional funding. It's really takes a lot to pull these things together. I do some consulting work. I don't think any of those really present a conflict, but they are funding some of the work that you'll see. So here, what I want to talk about is really concept of some invisibility and these unknown unknowns. Certainly, even though I am part of the LGBTQ plus community, or in academia, what we call sexual and gender minorities, I myself have been on this journey of how do we actually address unassessed critical differences between sex, gender, sexual orientation, gender identity, and gender expression, which I'll talk a little bit about what those mean, because they're really fundamental concepts to doing critical research in this work. And then some of what we're doing in terms of active research here to elucidate some birth outcomes and family building outcomes, as well as sensitizing you, hopefully in whatever capacity you're working in this space, to start to think about how you can also extend this research, because it's really a big, big team effort. So many of you have probably seen this before. It's a little cartoon, and it's not because I'm making light of this, but cartoons help stick, right? That's why we give them to kids. But it's a mental model, okay? And it's a mental model. We call it the gender unicorn, and there's others out there. But the point here is to disaggregate concepts that we generally think are all together. So here we have this unicorn. All of us have this unicorn inside of us. That might be a surprise to some of you, but the idea that we have our gender identity, it's how we think of ourselves. So however you think of yourself as a woman, a man, a person of another gender, that's something that you have inside of your mind. And actually, nobody can know that just by looking at you or anyone else. The gold standard is asking someone, but they also have to feel comfortable enough and safe enough to disclose. And we know from some other research I won't be talking about today, context and safety really matter about whether people disclose this or not. Now, that rainbow thought bubble, that's different than how you present yourself, gender expression or presentation, which is something that you can see about someone, whether they're wearing for a particular culture, time, region, something that's stereotypically feminine, masculine, or maybe representing people of or expressions that are of a mix or outside of both of those. And you'll notice as I'm talking through these that they are arrows, meaning that they can move along these. You can have kind of mix and match across these, but they are different concepts. So gender identity is different from gender expression, is different yet again from sex assigned at birth. So some people will just say sex, and that's okay. But usually what we're doing as healthcare providers, whether it's your obstetrician or the pediatrician or the nurse or parents, usually at the time of birth, we look at somebody's genitalia and we determine, how does that reflect or likely reflect their chromosomes. And that's really why it's discussed as assignment at birth. We may actually not know what their internal reproductive organs are, although they often align with external genitalia, not always, but that is different than how someone thinks about themselves, their gender expression, their sex assigned at birth. And it's different again from how people might be sexually attracted to or romantically attracted to. So I'm going to give you an example of me. So I'm a cisgender woman. What does that mean? It means that my sex assigned at birth is sort of consistent with that commonly associated with the gender that I have. So my gender as a woman kind of lines up with what most people think of when they know about my sex assigned at birth. But a lot of people, that's not the case. Now, I'm a cisgender queer woman, meaning that although my gender identity as a woman and my sex assigned at birth kind of line up with what is commonly thought of in society, my partner is a woman, and that is not something that we are generally planning for in our research and our clinical care. That I'm not just going down the expected mold. And the point is that many people are kind of at different places on these different constructs, and we have to allow for that, and not just allow for it, plan for it, think about it in our research and our clinical care. And that's different than who people may be romantically attracted to. And what's really missing here is sexual behavior, right? Who people may be having sex with or not, as that predicts, are they going to get pregnant? Are they not? What are their opportunities for pregnancy and family building? So that's a little bit long-winded, but I just wanted to make sure that you're hearing these things, because I'm going to use a couple of terms, and these are really critical constructs to understand. So at this point, people might be saying, gosh, man, I'm busy and I've got a lot of research to do. And how do I kind of summarize all this? So sex or sex assigned at birth was what between your genes, as in blue genes, but more importantly, your chromosomes, whereas gender identity is what's between your ears. So only has to do with the individual person and not who they're partnered with. And that's different than who somebody, gender identity is, kind of who you go to bed as, internally. It only has to do with the index individual, versus sexual orientation, who you go to bed with. Now, what does this have to do with pregnancy and family building? Well, the world of pregnancy and family building is very much, and birth, very much built on the construct still that that people who are pregnant are women, and that they are partnered, and that they're cisgender women, so their gender identity as a woman, and that they were assigned female sex at birth, and that they are partnered with men. And that is kind of how all of our forms and all of our research is predicated. And when we're thinking about sexual and or gender minority people, they're kind of breaking that traditional mold and don't necessarily fit in what we're expecting. And so we have to start to expand how we're doing our research and how we're doing our clinical care to really allow them into our fold in a visible, accurate, and inclusive way. So I want to give you a story here. So 2015, San Francisco Bay Area, 37-year-old cisgender queer woman and her partner, also cisgender queer woman, they want to have a kid. And one of them wants to be pregnant, the other one doesn't. And TL, the one who doesn't want to be pregnant, works for a big tech company and stored their eggs a few years prior. And they want to use TL's eggs in JM's uterus, okay? This is called reciprocal IVF. And they go to the fertility clinic and they say, hey, this is what we want to do. And what can we tell them about fertility outcomes or success? How common is this? What are the outcomes like for LGBTQ plus people? How long do you try with one partner, then the other? What are those outcomes? What are the optimal practices for prenatal care for two women going through prenatal care? What are support groups look like? Mommy and me groups. What should labor and delivery look like postpartum to optimize the care for these communities? And what barriers and facilitators might they be facing? How much it will cost them? What legal paperwork do they need? I mean, there are hundreds of questions that I could have listed here that we don't know for this community. So this is where it comes to this title of these like known knowns and known unknowns and unknown knowns, and you could get kind of into tongue twisters here. But in research, we're always in somewhere in these, right? And we're building on past research to try to advance our future research. And one of the challenges with doing research around sexual minority people is we don't even know the fundamentals of how many people there are and what they're doing, and a basic epidemiology, much less sort of more detailed translational care pieces. And so this is why I kind of put this big red arrow in that I think much of the pregnancy and birth outcomes piece for sexual minority and gender minority people, so folks who are not heterosexual and folks who are not cisgender, is really an unknown because we don't even know if kind of our models for thinking about pregnancy and birth apply. So to extend the story, JM and TL went on to create embryos and become pregnant. And there was a lot of excitement, but also exhaustion, because at every turn, they were asked, well, you know, when there were kind of normal-ish bumps in the road of maybe some first trimester bleeding, third trimester bleeding, you know, where's your husband? Can he come? What does he think? You know, are you going to be able to take time off of work? Forms like at the NT where it was asking about the mother and the father, but they used a sperm donor. And well, does the uterine environment matter? Does the egg environment matter? Everything didn't seem to fit. And then when it came to birth, the biggest fear for JM, who was pregnant, was actually not about the delivery, but loss of rights and loss of the kid. Because all over the place, there was just nothing in there that was talking about somebody who had a woman as a partner. So probably, maybe some of you who know that this story is actually my story. And it continued. We had uncomplicated delivery. We did reciprocal IVF, but then some other challenges ensued. So this is my kiddo who's almost 6. This is a long time ago. But despite being like every queer couple I know who came to the labor and delivery with a sheaf of legal paperwork about this thick from judges saying, you know, on the birth certificate, please put these people's names, we had to threaten to sue the county of San Francisco and then the state of California to get both of our names on the birth certificate, despite the fact that we had legal paperwork to do so. So, and we had to, like, everywhere we went, cross out things like father and these things. So I say this not just because it's all about me, but as an example, you know, I spoke to the patient, i.e. me, it was fine to share this stuff. And, but just to elucidate all of the challenges. So my kiddo didn't have a birth certificate for the first month of life because we were threatening to perhaps sue. And I'm an OB-GYN, as many of you know. My partner's a lawyer. And despite that, with all of our privilege and all of the money we had spent, this is what we were thinking about postpartum instead of other things, in addition to other things. So why is this? Why is there so much invisibility and struggle? Well, I'll just say briefly, there's just not a lot of data collection, sexual orientation, gender identity, the things that we would need that we kind of take for granted. How many, you know, people are there between the ages of 18 and 75 in the US? How many are African-American or Black, Hispanic, Latinx, Asian American? All of those kinds of other characteristics, how many speak which languages, just not collected in terms of sexual orientation and gender identity. And it was planned to be in the 2020 census, but our last administration removed it. There are plans to include sexual orientation and gender identity in 2030 census. Exactly how to do that is not totally clear. And so we have extrapolated data about percent of population. In case you all are saying, well, we're kind of smallish population. Most of my patients are, you know, cisgender straight people. I'm gonna do really great care and then I'll take care of everybody really well. I think that's not necessarily as applicable in so much as the population is growing and we know that there's some real differences in care needs. So when we look across LGBTQ plus people by percent population, California is not just in the green, the highest populous state or highest category of populous states here in the West, but is actually the most populous state for LGBTQ plus people at overall adult populations over 9%. And a lot of those people are raising kids. So we kind of go down in California, where about 20 to 30% of LGBTQ individuals are raising kids. I'll get into the fact that we don't know quite how those kids, they happen to come to have those kids. But we know that this is actually growing demographically. We are expecting to see even more people. So when we look at 2021 Gallup data, because we don't have census data, we actually know that while overall in the US population, about 7% of people are LGBT, 7% of adults are LGBT. When we look at the youngest population of the youngest generation, Generation Z adults. So those are adults who are 18 to 24 right now. Almost 21% are LGBT. So 1 in 5. Okay, so these are our prime reproductive age people. 1 in 5 are LGBT, and 1 in 48 or over 2% are transgender. Okay, so these are big numbers. So even though those maps that I showed you a moment ago were showing kind of a slightly lower percentage, we think that there's a lot more people coming through, and most of us have not been trained on how to take care of LGBT people. And so because we weren't trained and we aren't taught to ask, but we think that there are healthcare and health disparities, the differences, we think that those health disparities and differences are pretty unknown and poorly characterized, these unknowns, mostly because medical providers and researchers don't ask about SGM health, even more specifically in pregnancy and in gender components of medicine, and that leads to a lack of SGM health data, and these health disparities persist. So my colleagues and I wanted to do better. And so we said, okay, let's start doing surveys and research on SGM people who are, thinking about getting pregnant, not wanting to get pregnant, basically the whole gamut of sexual and reproductive health. And we said, okay, let's go to the literature and get the standard questions, and then we'll just, administer them to LGBT people. So here are some of the standard questions.
I
These are
don't know
two.
if I added in.
Hello?
Please mute yourself.
So, oh my gosh, I ran out of time is flying. Oh my goodness, I didn't get to things. So I didn't realize it's almost 12:45 or 12:40 here. So biased questions didn't work for LGBT people. They presume the gender of partners, they presume what sex means. And so we wanted to do better. We designed new surveys. It took us 2 years to design surveys with community groups. The first thing that we did was look at the pregnancy intentions and outcomes of trans people. And we administered this in the PRIDE study. In the interest of time, I won't go into the details about the PRIDE study other than to say it's a prospective longitudinal cohort of sexual and or gender minority people. We have about 24,000 people enrolled, and we've been collecting data now for longitudinally for, we're in our 6th full year of data collection, but we started in 2015. We're community engaged. So that means we bring in participants at every step of the research to make sure that what we're doing is real, relevant, and respectful to the community, and really reflects kind of things that we may never have thought about before in research. And one of the things that really has come through in our first study of those pregnancy intentions that took us 2 years to design that survey was that people have a multiplicity of identities. Maybe that doesn't sound so dramatic, but when we looked at gender identity of people who were assigned female at birth or intersex at birth among a sexual and gender minority cohort, 61%, we allowed them to select multiple gender identities, and 61% indicated multiple genders. Okay, so in your forms, if you're asking, are you a man or are you a woman, you might be missing a whole gamut of who people are. Same thing with sexual orientations, 60% indicated multiple sexual orientations. Now, there are lots of limitations with our research and this initial project. As with all projects, one of them was that 87% indicated a white-only race or ethnic background. So not generalizable, but still some signal to carry forward of the multiplicity of identities and experiences. We also asked people about the language that they use for their bodies. This is published. I won't go into this just in the interest of time. But this is the largest study to date to talk about pregnancy intentions and outcomes of transgender and gender expansive people. So these are folks who current gender identity differs from that commonly associated with their sex assigned at birth. So they identify as a man, they identify as a non-binary person, but they were born with a uterus, ovaries, and tubes. They were assigned female at birth. So previously unstudied at this scale, we had 1,700 people who provided data around their sexual and reproductive health, complete enough to analyze, and 12% had had at least one pregnancy. And pregnancies happened even while on testosterone, which is a big misnomer in the community that testosterone that's used for gender affirmation will be contraception. It's not. It does not fully suppress the HPA axis and ovulation. And that 11% of those folks wanted a future pregnancy, and that about the same amount, not the same group, felt at risk for an unintended pregnancy. So a lot of unmet needs here. People who want to have a pregnancy, people who don't want to have a pregnancy, people who are using medications that could unknowingly to them, not be contraception. And unfortunately, we didn't have the racial and ethnic differences to really dive into the fact that probably there's real differences among the experiences of, for example, two Black men who are having a family by pregnancy, as in the picture slightly on your right, or in the middle there, which is Caden and Dominic. Caden in the yellow bandana is a trans man partnered with another man. So they're two gay men. One is trans, one is cisgender. And then versus Biff and Tristan, who are also two gay men with one trans man who is pregnant and then one cis man who are white. So probably their experiences are really different. Okay, so unfortunately, we haven't been able to go there yet. Much like in data on cisgender women, pregnancy outcomes by intention of that pregnancy were pretty similar to cis women. So if you intended to have a pregnancy, most of those pregnancies resulted in a live birth. If the pregnancy was unintended, a good proportion, or almost 40% of those, resulted in an abortion, and about 37% resulted in a miscarriage, with fewer, about 20%, a little over 20% in a live birth. So these data were never presented, were never known before to our community. So there's some differences in terms of real differences by gender of transgender individuals having different experiences than cisgender folks, but then in some ways, like these data, very similar. So again, unclear yet exactly what the influence of gender is. What we do know is that abortion experiences were quite different. So there are unintended pregnancies, and trans and gender expensive people need abortions. And what we were finding was that they were presenting later to care, or achieving and obtaining their abortions at a later stage of care. And almost 20% who had ever been pregnant attempted to end their pregnancy without clinical supervision. So obviously this is something as medical providers we need to be paying attention to, because unfortunately in our current medical and socio-political landscape, we unfortunately expect that those numbers will go up given the barriers to care. And some of those barriers, when we asked participants and we said, what can we as medical providers do to improve abortion experiences? They said, well, you can improve accessibility and quality of abortion care for trans and gender expensive people by using affirming language, both in your intake forms and your provider interactions, okay? So with that in mind, we know that the PRIDE study is a convenient sample. It's, opt-in. We know that people who opt in to do some kind of research like the PRIDE study is very different than the general population, and we wanted to get into population-based data. And so this is where I got together with many people who I think are in the audience here today, and if not, I really want to much gratitude to folks at the CMQCC and Stanford MCHRI, as well as our department, which really afforded us the opportunity to say, well, everybody who gives birth pretty much has a birth certificate. There's a pretty tight accounting there, right? And almost everybody at some point comes through hospitals, or we have information about what happened in their health experiences. And so we looked at those data in a couple different ways. And one was that we actually took a step back and we said, how good are birth certificates for telling us about whether somebody is SGM or not, and how much baked in assumptions about who partners and parents are there in birth certificates. And this effort was actually led by a med student, Adri Zhang, who really looked state by state and found that birth certificates, there's over 30,000 different forms of birth certificates kind of floating out there, even though there's a standardized national one. and that there's some very gendered components that actually conflate concepts here. So we looked at things like, how is someone identified as a birthing person in each jurisdiction, and how is someone identified as a non-birthing person, right? So is that birthing person assumed to be a woman, assumed to be a mother? Is that non-birthing person assumed to be a man, assumed to be a father? And how does each jurisdiction make a distinction between parentage for married and unmarried parents? So there's a lot of like collapsing of these concepts into single things in birth certificates, which then carry through to a lot of different things in an individual's life, but also in how we use it in research and clinical care. So I won't go into these pretty tables too much, other than to say that 47 states define a birthing person as a woman, and that in the mother role. So they bring all those together. And you may say, well, that's almost always true, but there are things like surrogacy on the rise or adoption, and that may not even work, even if we're not talking about SGM people. And then 42 states define the non-birthing parent as a man or in the father role. And there were 0 states that really asked about parents, sex assigned at birth, and sexual orientation, gender identity as distinct concepts. Not surprising, but really those are distinct medical and sociological differences that we need to start tracking. So there were some really major assumptions about birth certificates, that sex, gender, birth roles, parental roles, and contributions to pregnancy were collapsed into big categories that conflated things. There were assumptions about marriage that harm probably all kinds of communities, and that leads to difficulties in demonstrating parentage if you're not married, or if there's barriers, political barriers to actually obtaining a marriage. There's exclusion of non-dyadic parents. So I'm not even talking about the fact that in many communities, there's more than 2 parents or single parents, and there are also challenges there. And then there's policy variations across jurisdictions, which make things very complicated for people. And so basically our recommendations were, let's get really accurate. And if we're going to collect things like gender, if we're going to collect sex assigned at birth, if we're going to collect intended parent role and social roles, let's collect those as separate variables, because they all have meaningfulness in our society, but they mean different things. So let's disaggregate them and collect them separately, especially as our medical communities advance and we start to use egg from one person, sperm from another person. And it may be that the person who provided the egg is different than the person who's gestating the pregnancy. And we need to account for all of that now in our medical care. So we, just in the interest of time, I won't go into this more, but we started to look at more of how many people and how many different potential parental structures there were. There's 16 different parental structures in California that we could see from California birth certificates. So California made a unique change, or a pretty important change in 2016 that allowed these data. They said, for a birthing person, we could designate their parental role and, on the birth certificate, you could disaggregate who gave birth and who didn't give birth. So 2 parents, but at least it was kind of like giving birth versus not giving birth. And then for each of those roles, the person could be a mother, a father, or a parent. So that, for the first time, allowed us to look into California birth certificates and say, gosh, what are the parental structures here, and what do they tell us about sexual and/or gender minority people? And there's 16 potential kind of combinations of those different birthing and non-birthing roles, and all 16 are represented in birth certificates when we looked at this with almost 2 million people. And but it still was complicated and difficult for us to very with a lot of confidence identify who was SGM. But we used that with some caution to identify SGM people versus not. And we published about those health disparities. And Dr. Leonard, who I believe is on the call, is the lead author on this paper, which looked at birth complications and birth outcomes among likely SGM people. We looked at mothers who gave birth with mothers. We felt pretty confident if there were two mothers on a birth certificate that they were likely an SGM couple. And we looked at any father giving birth. And we found higher rates of multifetal gestation, higher rates of labor induction, higher rates of postpartum hemorrhage, sorry about that, and higher rates of severe morbidity. These are way above just signal, and they held strong even in adjusted, rigorous adjusted analyses. So there are some other pretty kind of diagrams on the next slides that basically say the same thing. So I'm going to skip across to those just so we can leave some time and just say these were some of our DAGs, if people know what directed acyclic grafts were, to try to understand all the factors that might be that we needed to account for in thinking about how sexual and gender minority status may influence obstetric outcomes. You can look at these in the paper, but just to say it's kind of complicated. If you hadn't noticed, pregnancy and birth were sort of complicated. We have a lot of upcoming investigations, like how are LGBTQ plus families made? We've talked about pregnancy and birth, but that's not the only way to build a family. Adoption, fostering, surrogacy, other pathways that use assisted reproduction and not. And do SGM parents have different health outcomes than non-parents? Also, what is the role and experience of folks who are assigned male at birth, who are SGM, whether that's cisgender sexual minority men, transgender women, or gender expansive people, and does birth location differ? So these are some of the studies that we have in planning or underway. We have questions and active analysis going on all of these. We have some community listening sessions to really bring community members into this and ask people, what do they want to know about how to build their families and what's important to them, and what barriers and facilitators have they experienced in building their own families. So if you happen to know people who are trans women or trans feminine people or non-binary and gender expansive people, we have some community listening sessions coming up. And with that, just so we have like a few moments, I want to say, just don't assume anything I ask. And I will leave time for questions here. So hopefully that was a helpful little tour de force of some of what many people in our group are doing together.
Juno, thank you so much for this presentation, and even with the time constraint, I think you really managed to delineate so many of the critical points and educate all of us. I see Dr. Crow's hand is up.
Just a quick question. Why do you think you saw the increase in complications?
Yeah, among mothers giving birth. And I should say, actually, we didn't see it. I skipped over it, but we didn't see that in fathers giving birth. So very interesting. Those populations look different. Dr. Leonard and I have spent a lot of time talking about this and building other grants and analyses. We think that it really comes down to this concept of minority stress, stigma, and discrimination. If at every turn people are, treated just a little bit differently, or there's just that much more delay, or different protocols are used, or there's just, all of those things build up, I think, both in how providers treat people, but also on how people may or may not present to care. But we're writing some grants and thinking about how do we interrogate that in a rigorous way. But that's like the only thing that we can really explain. There were some other things like, okay, this group is older, but even when we accounted for age, or, oh, this group has multifetal gestation, but we looked at singletons too, and that, all those associations still held. So the quick and easy answers aren't quite there, and it was much bigger effect on some things than what we thought.
Thank you.
Maury, you had your hand up.
Yeah, hi. Thank you so much, Juno. This was really absolutely terrific. I just wondered in this SMM group, the SMM data, maybe I missed it, but was hypertension and diabetes increased as well?
Yeah, so diabetes was not increased, despite the fact that most people will say And actually our preconception data looks like that there's higher levels of overweight and obesity. We were not seeing differences in diabetes. And then hypertension, there was some signal that was ameliorated with our adjustment. We did see a difference in pre-existing cardiac comorbidities. So we have some real questions about kind of how these groups might be different at the outset, like as they present to care or as they present for pregnancy, those types of things that might be predicting this. But the short answer is no, not directly on the hypertension and diabetes front. And Stephanie, I don't know if you want to add anything to that.
No, except that at least with like the kind of chronic health conditions, the main difference we did find is in mental health conditions being much higher.
Okay,
Right.
but Stephanie, in the ICU admission, the non-transfusion ICU admission, was severe hypertension overrepresented or not in that group?
So I think Juno's saying that where chronic hypertension is very similar, but for preeclampsia, it was higher. In SMM, the composite was higher. We didn't look at individual indicators like stroke or something. We would have to do that, which would be really interesting and a great idea.
I think it would be an interesting little sidebar thing to look at that, because that could also reflect differences in treatment approaches.
Yeah, I think that's a great suggestion.
Yeah, good
Thank you.
point. Thank you, Dr. Drusen. Other questions?
You covered a really nice, powerful landscape of issues. What do you feel is the most pressing area of investigation as it relates to birth outcomes in pregnancy?
I think the most pressing is probably how to kind of optimally support people at the point of birth and delivery and postpartum. I think that and I think that's actually, there's real research to be done there. I think there's also just implementation of what we know. So if you think about mommy and me groups or postpartum support groups, postpartum depression screening, all kinds of things are really framed as if people have a partner. Not everybody has a partner, right? And so the social supports and those types of things, whether it's a single parent or if a sexual minority person. So I think we need to do better research around that, but also I think there's just some implementation that we could just already do that I think would improve outcomes and support. And I think, really there is some real important work in terms of implementation of how care might be different and needs might be different in terms of support. Optimal prenatal care or issues that are different. That's why it's in a little bit the unknown unknowns, because we haven't even asked in so many ways.
Well, we are exactly at 1 o'clock, so you pulled it off beautifully.
Thank you.
Thank you again. And thank you everyone for joining our monthly meetings, and have a wonderful rest of the week. And thank you again, Juno.
Thank you so much. Thank you, everyone.